Good evening, friends. I think a couple of minutes delay. Sorry for that. We have two cases for discussion for this Friday postgraduate clinics. We have very eminent faculty joining us. Professor V.K. Kapoor, sir, he's right now the Pro Vice Chancellor at the Mahatma Gandhi Medical College, Jaipur. And we have Dr. Arun Abhinav Sonkar, sir, from KGMU Lucknow, and we have Dr. Vikas Singh shortly joining. Vikas, I think, sir, has joined. Good evening, Vikas, sir. Vikas Singh is professor and head of the department. Yes, sir. At RML Medical College, Institute of Medical Sciences at Lucknow. And we have our own senior faculty, Dr. Nishikant, Dr. Ajib Sahai, and other senior faculty who have joined today. Warm welcome to all of you. Friends, we have two important exam cases. One is a long case, a case of obstructive jaundice, to be presented by Dr. Supratik Saha. Supratik is from All India Institute of Medical Sciences, Bhopal. Thank you, Dr. Shamita Madam, for permitting. I'm sorry, Dr. Swagata Brahmachari ma'am, for permitting this candidate to present a case here. Madam will be joining shortly. And followed by, we have a short case, carcinoma tongue. This is from the Apollo Institute of Medical Sciences and Research from Hyderabad. Dr. L. Sridhar and Dr. Faizi are the professors who have permitted this boy to come in for the presentation. So friends, the long case is for an hour's time. Usually they go through the history part of it, and then the faculty go back, revisit the slides to ask questions or give their comments. And then they go through the clinical part of it. At the end, they will have to revisit the slides for the faculty to ask questions. Then we have another half an hour for the discussion. The initial discussion can be pertinent to the clinical part of it, investigations, and later on to the management and the complications as well. So we have an hour's time. Faculty, I request you to give the answers if the candidate gets stuck or he gets blank, something, so that we can move on further. And if I also would like request each one of you to give the correct answer as an examination pattern. As an examiner, what exactly you will be getting convinced when the candidate replies as an answer for your question, if the candidate is not giving the appropriate answer. With that few words, I now hand over the sessions to the faculty. I welcome Dr. Supratik. Can you try sharing your PowerPoint? Introduce yourself, your unit chief and the head of the department, and start your presentation. Good luck to you.
Good evening, respected faculties. Sir, is the PPT visible, sir?
Yeah, you are good, Ma. You are good. Make it full screen and you should be ready to go.
Okay. Good evening, respected faculties. I am Dr. Supratik Saha, third year resident from Department of General Surgery at AIIMS Bhopal. Today, I'll be presenting a case. My patient is Mr. X. He is aged 60 years, a resident of Gandhinagar from Betul in Madhya Pradesh. He was previously a farmer. Currently, he is unemployed. He belongs to lower socioeconomic status. So, this patient presented with complaints of yellowish discoloration of his eyes since last 3 months, itching all over his body since 3 months, and abdominal pain since last 1 month. So he was apparently well 3 months ago when he first developed yellowish discoloration of his eyes, which was first noticed by his son. It was insidious in onset and gradually progressive. It was associated with history of passing clay-colored stool and high-colored urine for the same duration, that is 3 months. It was also associated with itching all over the body. There was no history of waxing or waning of jaundice. Initially, the patient did not have any complaint of abdominal pain, but since last 1 month, he is complaining of having pain in the right side of upper abdomen. There was no history of any prodromal symptoms like fever, malaise. The patient complains that he has pain in the right side of upper abdomen since last 1 month. It was dull aching in character, mild to moderate in intensity. There was no radiation or no referred pains, not associated with any meals intake. There was no aggravating factors. He told that it subsided on taking oral medications. Patient also has history of loss of appetite for last 3 months. There was history of loss of weight also. He lost about 5 kgs in the last 3 months. There was no history of blood transfusion tattooing. There is no history of vomiting. There is no history of altered bowel habits. No history of hematemesis melena. No history of fever with chills. No history of reduced urine output, difficulty in seeing at night. No history of cough, chest pain, hemolysis. No history of loss of consciousness, and no history of back pain. Now coming to past history, patient told that he was taking treatment from a local practitioner for last 3 months where he was conservatively managed, but there was no resolution of symptoms. Patient had also told that he has gone to a quack for treatment where he was treated with heating rods over the abdomen. There is no history of any similar complaints in the past. There is no history of any medical comorbidities like type 2 diabetes mellitus, hypertension, thyroid disorders, any previous history of TB. He gave history of trauma to the right eye 40 years ago while working in the field, for which he lost his vision in the right eye. Now, coming to personal history, patient takes mixed diet. There is loss of appetite because of reduced oral intake. There is patient told that he had adequate rest and sleep. He was previously a smoker. He smoked for 15 years, and now for the past 20 years, he has not smoked. He was also alcoholic. He drank for 15 years, but he has quit drinking since last 20 years. There are no history of any other addictions. There is no history of any similar complaints in any of the family members. No history of any syndromic diseases in the family members. To summarize the history, a 60 years old male who came to our OPD with complaints of progressive yellowish discoloration of his eyes since last 3 months, associated with passing clay-colored stools, high-colored urine, and itching all over the body. There was no history of waxing and waning of jaundice, no history of hematemesis or melena. Initially, there was no abdominal pain, but since last month, patient is complaining of dull aching pain in the right upper quadrant of the abdomen. There was no associated prodromal symptoms, and there is history of significant weight loss.
Okay, so what's your differential?
Yes, sir. Sir, an elderly
You got a
male
slide showing a
presenting with.
differential diagnosis. You got a slide?
Yes, sir. Sir, based on the complaints of the patient, my provisional diagnosis, a patient presented with surgical obstructive jaundice, probably due to malignant etiology.
Okay. You said just next, the previous slide, you said there was no family history. Who all are
Yes,
there
sir.
in the family?
Sir, he
What does
he lives with his son, and there is one younger brother in his side of the family.
No wife, no daughters, nothing. Brothers.
He has wife, but she does not live with him anymore.
Okay. What about his parents? Look, when you have a patient of malignancy, I would like to know his social history. What is his level of education? How much does he understand? Can he afford the treatment? Right?
Yes.
It
No,
is
sir,
very
he actually
important.
belongs to. Yes, sir. Yes, sir. He actually belongs to a very low socioeconomic status, sir.
Okay, so why do you think it's surgical jaundice?
Sir, he presented with, first of all, he's a 60 years old male, so elderly male, presenting with initially painless progressive jaundice. And he has history of passing clay-colored stools, high-colored urine, and he has history of itching all over the body. All these features are suggestive of surgical obstructive jaundice, sir.
Okay, by his history, can you come down to the point of what kind of lesion could it be which is causing this kind of jaundice? Where could the lesion be just by history?
Sir, there is obstruction to the flow of the bile, because of which patient is having obstructive jaundice. Sir, since the duration is very small, that is 3 months, the obstruction will be very proximal in the biliary tree.
So So what are the conditions which can cause this? Painless progressive jaundice with pain after a couple of months?
Sir, mostly malignant conditions are responsible for painless progressive jaundice of such short duration. So, among differentials, sir, based on history alone, sir, I would like to keep malignant pathologies like uh, most common is carcinoma gallbladder, followed by carcinoma head of the pancreas and periampullary carcinoma.
Carcinoma gallbladder, and next would be?
Sir, next would be periampullary carcinoma and then carcinoma head of the pancreas.
Okay. So why are you putting carcinoma gallbladder as the first differential? Does carcinoma gallbladder present early on with history of jaundice?
No, sir. They do not present with history of jaundice. But I would like to keep this as my first differential, first of all, because it is the most common biliary malignancy. Second point is that initially the jaundice was.
Is it the most common biliary malignancy? Is it?
Yes, sir.
Okay. Next. So, how does a patient of carcinoma gallbladder present with? Usually.
Sir, most of the patients are asymptomatic. They are diagnosed incidentally.
Or they present with secondaries.
Sir, for a moment, sir,
yes.
I'm sorry to interrupt. We have Professor Abhinay Varon also joined. Warm welcome to you, sir. I think you had some challenges in joining. Please join the discussion, sir. We have the candidate just running through the history. I've sent you the slide deck to your PowerPoint also, sir. Sir, please carry on, sir. Thank you. Sorry for interrupting.
Professor Kapoor, please, sir. Sir, please.
Kapoor, sir, and
you please go back to your negative history slide.
Yes.
A slide before where you talked of prodrome, I think before this.
Yes.
Why did you ask about prodromal symptoms?
Sir, prodromal symptoms like fever, malaise, they are usually associated with infective conditions like viral hepatitis. So to rule out viral hepatitis, I have asked for prodromal symptoms.
What does the prodrome of viral hepatitis include? What all does it include? Is it only fever and malaise?
Sir, it can include malaise, vomiting. Then, sir, there can be abdominal pain also. Yes, sir.
It includes low-grade fever,
low-grade fever, yes, sir.
Weakness, malaise, tiredness, nausea, maybe vomiting. Those who smoke, they develop an aversion to smoking. And there is mild to moderate, dull, continuous ache in the right abdomen. And all this happens before the jaundice appears. That is why it is called prodrome. So whenever you say prodrome, you should always give the complete description. Okay.
Okay, sir. Okay.
You said he has lost some weight. Go to that slide.
Yes.
You think it is a significant weight loss?
Sir, my patient was 48 kilos 5 months ago.
You didn't mention that. You didn't mention the baseline weight. If he knows that he has lost 5 kg, he must have weighed himself earlier and he must have weighed him now.
Yes, sir.
He is a farmer who belongs to a low socioeconomic status. Are you sure that he knows his weight before and now?
Sir, initially, before 3 months when he developed the jaundice, he has gone to a local practitioner. And in that, during that time, he told that he has measured the weight. His son told that he has measured the weight and it was 48 kilos. But on this visit, he weighs only 43 kilos. So he has lost 5 kilos.
So probably he has lost even more because he must have lost some kg weight by that time also, isn't it?
Yes, sir. Yes.
So you think this is a significant weight loss?
Yes, sir. Because he has lost more than 10% of his weight in just 3 months.
What is the definition of
significant
weight loss?
Definition of.
What is the definition of significant weight loss?
Definition of
more
significant
than-
weight loss.
Yes, sir. It is defined as, sir, more than 10% body weight loss in 6 months.
If the patient has history only of 3 months, how would you know weight loss over 6 months?
Sir, he has already lost greater than 10%, sir, in 3
Agreed.
months only.
So it cannot be only one definition. 10% in 6 months. Some texts mention 5% in 3 months. Some texts even say that unintentional 2 kg weight loss in a month also is significant. So
Yes.
if the history is very short, you have to take that into account.
Yes.
Now, why do you mention no history of vomiting?
Sir, usually cases of viral hepatitis can be sometimes associated with vomiting. In our patient, there was no such
That
history.
you already covered in prodromal symptoms.
Yes, sir. Secondly, sir, there are malignant conditions which can give rise, which can be locally invasive and give rise to obstructive symptoms.
Like?
So there was no such. Like, sir, they can lead to gastric outlet obstruction also.
Which malignancies? Which malignancies which cause jaundice will also cause gastric outlet obstruction?
Sir, carcinoma, head of the pancreas and periampullary carcinomas.
Does periampullary carcinoma cause gastric outlet obstruction or duodenal obstruction?
Sir, if it is duodenal adenocarcinoma, in that condition, sir, it can lead to obstruction, sir.
Peripapillary duodenal carcinoma.
Yes, sir. Peripapillary, yes, sir.
And even carcinoma of the gallbladder can involve the first part of duodenum
Yes,
and gastric outlet obstruction. Next,
Yes.
you mentioned altered bowel habits. Why do you mention that?
Sir, altered bowel habits because, sir, patient, there can be associated other malignancies also in the patient, which can give rise to colonic growths, which can give rise to altered bowel habits.
That way, a patient with malignancy can have malignancy anywhere in the body. Second malignancy. Is there any direct relationship of malignant obstructive jaundice with altered bowel habits?
Sir, there can be involvement of in malignancy cases there can be involvement of hepatic flexure or the transverse colon as it lies in close proximity to the gallbladder. So that can be one of the reasons why their altered bowel habits can be there.
It's more likely to cause melena rather than altered bowel habit. So melena is okay, hematemesis is okay. What I'm trying to say that when you present the negative history, the sequence also should be more important, more relevant, and then less important and less relevant. Okay?
Yes.
Why did you ask about cough?
Yes, sir.
Why did you ask about cough?
Sir, I have asked this negative history in the symptomatology to rule out any metastatic conditions associated with the malignancy. If the patient has,
do pulmonary metastasis cause cough?
sir, the most common symptom will be cough, and however, the most specific symptom will be hemolysis. So, cough is the first and the most common complaint, sir.
Most pulmonary metastases are clinically silent. They will be picked up only on imaging. Only if there is a pulmonary nodule which is sitting close to a bronchus, it can cause dry, irritating, non-productive cough. More important is malignant pleural effusion, which causes dyspnea exertion. This is a very common mistake which students do. They mention cough and hemoptysis. They are not the common symptoms of pulmonary metastasis. It is dyspnea on exertion and, as you rightly mentioned, chest pain. Why do you mention loss of consciousness?
Sir, to rule out any metastasis to brain.
Is the first symptom of metastasis to brain loss of consciousness?
No, sir.
Again, the sequence of symptoms in intracranial metastasis is recent onset severe persisting headache,
Headache. Yes, sir.
followed by nausea and vomiting, and then followed by other symptoms like convulsions, focal neurological deficit. Loss of consciousness comes in the end.
Yes.
And similarly, for bone metastasis, if you have mentioned back pain as a symptom of bone metastasis, you should ask for back pain, recent onset bony pain, not necessarily back, it could be any other bone, and pathological fracture, spontaneous fracture following
Yes, sir.
trauma. So that is the complete metastatic history which you should present in any case with malignancy.
Yes, sir.
Pratik, why you ask history of, sorry,
What
Pratik,
is this slide?
why you ask
Yes, sir.
history of difficulty in seeing at night?
Sir, surgical obstructive jaundice usually leads to deficiency of fat-soluble vitamins, which are vitamin A, D, E, and K. Vitamin A deficiency can sometimes very rarely manifest as night blindness.
It is seen commonly in obstructive jaundice.
No, sir, it is not a very common feature. It can be seen only in 10% of the cases, sir.
You
Why
said
you included this rare thing in your negative history? As sir discussed, there are certain points. You have to
Yes,
present the negative history from most common, most frequent, then less
Yes.
frequent.
yes,
Keep it in this mind.
yes, sir. Okay, sir.
It is.
past history. Can I see the past history?
Yes, sir. Yes, sir.
You said no history of similar complaints in the past. Do you think a patient with malignant surgical obstructive jaundice will have similar symptoms in the past?
No, sir.
Unlikely, isn't it?
Yes.
You could have said
Yes.
no history of jaundice in the past, but you can't say
Yes,
similar.
sir.
There are
Yes,
some
sir.
patients who have a long history of a benign disorder, and then there
Yes,
is a
sir.
recent change in the pattern or in the symptoms, which indicates a malignant change.
Yes, sir.
Can you give one example in relation to malignant surgical obstructive jaundice, where patient could have a long history and now there is a history to suggest a malignant change?
Sir, a patient of initially a patient of cholelithiasis, long-standing cholelithiasis, if secondarily develops any malignancy,
Which
which is very
malignancy?
rare,
Which malignancy?
it's a gallbladder carcinoma.
Gallbladder cancer. Any other example? Bile ducts
Sir, hilar cholangiocarcinoma,
developing on a
vascular tumor.
background of.
Yes, sir.
So what is the long history? Patient with choledochal cyst can have recurrent episodes of cholangitis and then
Yes.
develop a cholangiocarcinoma. A patient
Yes,
with
sir.
chronic pancreatitis can have a long history of pain with or without endocrine exocrine dysfunction and now can develop a malignancy in the pancreas. So the symptoms will change. Now the symptoms will be like cancer of the pancreas. You mentioned two statements. You said duration is short, so I'm thinking of a proximal block. How is the duration related to site of block? There is no relationship between duration and site. So that cannot be the reason to say that it is proximal block. Okay. So when you have progressive jaundice, especially in a middle-aged or elderly patient, yes, you are right. You start thinking of malignant surgical obstructive jaundice. If
Yes, sir.
it is associated with pain, you start thinking of carcinoma of the head of the pancreas, which is associated with pain in almost 75 to 80% of cases, followed by carcinoma of the gallbladder, where pain is present in about 50 to 60% of cases. If it is painless progressive jaundice, you think of a periampullary carcinoma
Periampullary. Yes,
or
sir.
a cholangiocarcinoma or a tumor in the gallbladder, which is at the neck and has very early involved the common bile duct causing jaundice. That may also present as painless progressive jaundice.
Yes, sir.
Okay, please carry on.
Yeah, I would like to just add 2, 3 points, not related with the hepatobiliary system, but yes, the dialogue is that there is a recent change in the pattern of pain, which should be apt for cancer gallbladder, okay? Which would be apt
Yes,
for, if you remember Bailey and the old versions, the patient would be having the symptoms of dyspepsia and when they develop malignancy, or not because of dyspepsia per se, but when they develop malignancy, there's recent change in the symptoms also. And third is colorectal malignancy. There is always some history of tenesmus and other things, and then there is a change in the bowel habit. These all three should also be a warning sign for development of malignancies. Please carry on.
Yes, thank you. Now coming to general physical examination, a patient was examined in supine and sitting position with proper informed consent and with adequate exposure from nipple to mid-thigh. Patient was conscious, oriented to time, place, and person. His BMI was 20.36 kilograms per meter square, and the ECOG performance status was 1. Hydration status was adequate. Pulse was 88 beats per minute, good volume, regular rhythm, normal condition of arterial wall, no radio-radial or radiofemoral delay. BP 102/74 millimeters of mercury taken in supine position. Respiratory rate 18 per minute, abdominothoracic. Temperature 97.2 degrees Fahrenheit and saturation was 99% in bone. Pallor, as the patient was deeply jaundiced, could not be appreciated. Clubbing, cyanosis, and edema were absent. He was icteric. Yellow discoloration was appreciated in the sclera, palms, and soles. No lymph nodes were palpable. Now, coming to abdominal examination. Patient was examined in supine position with arms kept on the sides, exposed from nipple to mid-thigh and with proper consent. On inspecting, the shape and contour of the abdomen was normal. Umbilicus was centrally placed and inverted. Genitalia examination was also normal. There is an area of deepithelialized skin of size 2 into 2 centimeter on the right side of the abdomen, about 8 centimeters from the umbilicus in the right iliac fossa region. No pigmentation, striae, or engorged veins could be appreciated. There were scratch marks noted on bilateral flanks. All the quadrants were moving equally with respiration, no visible peristalsis or pulsation. Hernial sites revealed no swelling or visible impulse of cuff. Now coming to palpation. On palpating, the abdomen was soft in consistency. There was no guarding or rigidity. A single hard lump of size 5 into 4 centimeter, globular in shape, was palpated in the right lumbar region, extending to the umbilicus region, which became less prominent on head-raising test. All the borders were palpable except for the superior border, as it was continuous with the liver. It was non-tender. The margins were irregular. The surface was irregular, and it was moving with respiration. Fingers can be insinuated between the costal margin and the liver. The liver on palpation was enlarged in size. It was palpable about 4 centimeters below the costal margin. The span was 17 centimeter. The inferior margin was regular and smooth. Spleen was not palpable. The hernial sites did not reveal any cuff impulse on cuff. On percussion, tympanic notes were heard in all the quadrants. There was a dull note on the lump, which was continuous with the liver dullness. There was no signs of free fluid in the peritoneal cavity. On auscultation, normal bowel peristaltic sounds were heard. There were no venous bruit or hum. Per rectal examination, the perianal skin did not reveal any abnormality. The anal tone was normal. There was no mass or growth felt per rectum. Rectal mucosa was mobile. Finger staining with clay-colored stools was appreciated on the examining finger. The CNS examination did not reveal any abnormal findings, and so is first CVS, chest, back and spine examination. There were no abnormal findings noted. So to summarize, a gentleman aged 60 years came to OPD with complaints of yellowish discoloration of eyes associated with itching all over the body, loss of appetite and weight since last 3 months, and pain in right upper quadrant since last 1 month. Jaundice was progressive in nature, increasing associated with history of passing clay-colored stools and high-colored urine, itching all over the body, with no waxing or waning, no prodromal features, no fever. There was history of significant weight loss present. Examination revealed that the patient is jaundiced. Examination of abdomen revealed the hard globular, non-tender lump in right lumbar region of size 6 into 4 centimeter, extending to umbilicus, moving with respiration with irregular surface, most likely a gallbladder lump.
Okay. there are two things. You also wrote in the summary slide that there were no waxing and waning growth. And obviously,
Yes,
you
sir.
must have been referring to perimpulmonary cancer, right? So you
Yes,
have
sir.
to understand what is the meaning of waxing and waning growth. Then we move on to your examination also. Waxing and waning growth. What is the meaning of
Sir,
this?
sir, waxing and waning means that the intensity of the jaundice decreases with passage of with an episode of melena. However, there is no resolution in between. There, the patient will have some jaundice. It will never touch the baseline.
As far as I understand, waxing and waning growth mean that the level of bilirubin goes down. Patient bilirubin also biochemical evidence that bilirubin going down, and then it increases once again. Now the
Yes,
thing is
yes,
that this happens only in two conditions of perimpulmonary cancer. One is ampulla beta, and another due to adenocarcinoma, which presses on the lower end of CBD,
yes, sir.
right?
Yes,
And
sir.
it
Yes, sir.
form only 15-20% of the perimpulmonary cancers. So normally, when we understand that majority of the time it is head of pancreas, the liver and CBD, we should not. It is most of the time it is progressively increasing jaundice. Okay, we should not
Yes,
think
sir.
about waxing and waning. But it is most of the kind thing mentioned in Kedas kind of thing, which is very old. Now, in examination finding, it is a hard lump, right?
Yes, sir.
And when we talk about hard lump, obviously diagnosis of cancer gallbladder comes into mind. But
Yes, sir.
the lump cannot be globular in shape. When you say about globular in shape, something like a soft tennis ball comes into my mind. Okay.
Yes, sir.
If it is hard, it cannot be globular. This has been teaching, our teaching. Number one. Uh, but why the lump is hard? If it is, say, for example, let us go with your diagnosis and the patient has cancer gallbladder, why
Yes,
it
sir.
is a lump of cancer gallbladder? And why not something else? The second question is how it is formed.
Sir, first of all, I can palpate a hard lump in the right lumbar region.
You have made it.
Yes, sir. The surface is irregular.
Mm-hmm.
The surface is irregular, and sir, it is moving with respiration.
Mm-hmm.
The
Good.
upper border is not palpable separately. It is continuous with the liver dullness.
Mm-hmm. Good. Uh, Now, second question was how it is formed. If it is, say, example, we go with the provisional diagnosis of cancer gallbladder, how the
Yes, sir.
lump of cancer
Sir,
gallbladder.
yes, sir. Sir, the lump that is usually palpable in a gallbladder carcinoma is basically uh, it can be a growth in the fundus which is infiltrating into the adjacent liver parenchyma. That can be palpable. Or if it is involving any adjacent structures like the colon, the hepatic flexure, that can also be palpable, sir.
Mhm. Mm. So whenever you palpate hard gallbladder cancer lump, when you palpate it, the lump is like this. It is already T3 and T4, right?
Yes,
So
sir.
number
Yes, sir.
one, then we should not say it globular. Okay, number one.
Yes, sir.
Number two, you also wrote in differential diagnosis for carcinoma head of pancreas and perimpulmonary cancer. I think you should not write them separately, but they are part of one entity only. Uh, why, when you have examined the patient, you have taken the history, examined the patient, the lump is hard.
Yes, sir.
So, do you think the second provision diagnosis of perimpulmonary cancer head of pancreas fits into the differential diagnosis?
No, sir. They do not
Right.
fit into the diagnosis.
Why?
Uh, Sir, because in that cases, I would be able to feel a smooth uh, globular lump in the right upper quadrant.
Mm-hmm.
That will not be hard
Mm-hmm.
because in those conditions, the primary pathology is downstream. It is not in the gallbladder. So the gallbladder will just be distended and it
Yeah.
will be soft.
Till history, you can think about, you can put in a diagnosis of perimpulmonary cancer head of pancreas. But probably when you
Yes, sir.
examine the patient, the lump is hard
Yes, sir.
and it looks like gallbladder lump. You should not say about perimpulmonary cancer. They don't present like this.
Okay, sir.
Uh,
Okay, sir.
we
Okay.
will let Professor Kapoor sir to also ask question or other people to ask question, then we move on to investigation, right?
Okay,
Go
sir.
to the general physical examination. Yeah, next
Yes.
next one.
Yes.
Next. Next slide.
Yes, sir.
What is more important, cyanosis or pedal edema and icterus?
Sir,
In this
pedal edema.
case,
Pedal edema, sir.
so the important findings should come first.
Okay, sir. Okay, sir.
You said no lymph nodes palpable. Which lymph nodes you are looking for?
Sir, on examination, sir, I could not palpate any intra-abdominal lumps which could be suggestive of intra-abdominal lymphadenopathy or
This is general physical examination. This is not abdominal examination. So when you say no lymph nodes palpable, which lymph nodes you were looking for?
sir, I palpated the cervical lymph nodes, the supraclavicular lymph nodes, the axillary lymph nodes, and the inguinal lymph nodes.
Which is the most important group of lymph nodes in this case?
Sir, the left supraclavicular, sir.
That is what you should say. If you are
Yes, sir.
thinking of an intra-abdominal malignancy or testicular malignancy, then left supraclavicular lymph node is important.
Yes, sir. Virchow's node.
Thinking of a head and neck malignancy or esophageal malignancy, then any cervical lymph node is important.
Yes, sir.
If you are thinking of tuberculosis, then upper deep cervical, the jugulo-digastric group of lymph nodes is most important. If your differential diagnosis is going to include lymphoma, then all lymph nodes, including cervical, axillary, inguinal, epitrochlear, popliteal, all lymph nodes are important. So depending on what differential diagnosis you are going to entertain, you should specifically mention which lymph nodes you are looking for.
Yes.
Good. As far as the palpable lump is concerned, be very, very careful when you say that an abdominal lump is hard. Most abdominal lumps are usually firm. Maximum, you should say firm to hard. And the point which Dr. Abhinav was saying, if it is a distended gallbladder, which happens in the case of a mucocele, if it is a stone blocking the cystic duct, which happens if there is a periampullary or pancreatic cancer, a lower end block, and which can happen if there is a small tumor at the neck of the gallbladder, which is causing a distended gallbladder. That gallbladder is usually soft to firm. It is pyriform, oval, or globular in shape,
Yes.
and it moves with respiration, and it has a side-to-side mobility. On the other hand, the lump of a gallbladder cancer is usually firm to hard. It doesn't take the shape of gallbladder. It can be of any shape. It can be rounded, oval, irregular. It will move with respiration, but it does not have side-to-side mobility.
Yes.
If you have a distended palpable gallbladder, depending on what you are thinking, if you are thinking of a benign cause, it is a stone in the cystic duct, mucocele. If you are thinking of malignancy, then it is either lower end malignancy or a tumor at the neck of the gallbladder. Now, this waxing and waning, as Dr. Abhinav pointed out, periampullary carcinoma is not one cancer. It is a group of 4 cancers.
Yes, sir. Yes, sir.
As the word itself suggests, it includes ampullary cancer. It includes cancers around the ampulla, which also include lower end cholangiocarcinoma, a small pancreatic ductal adenocarcinoma, a carcinoma or cancer at the papilla. Papilla is the nipple-like projection on the medial wall of the second part of duodenum, and a peripapillary duodenal carcinoma. So only the papillary and the peripapillary duodenal carcinomas, when they slough, there may be temporary relief of biliary obstruction. There may be temporary relief of jaundice and pruritus, but it, as you rightly said, it doesn't return to normal. It comes back or it increases again. But this phenomenon is seen in a very small number of cases. Many students say that since waxing and waning is not present, it is not periampullary carcinoma. That is not correct. If it is there, it supports a diagnosis. But if it is not there, it doesn't exclude the diagnosis. Go to the summary, please.
And one more thing, sir. If you take the biopsy from the ampulla vator or peripapillary duodenal adenocarcinoma, sometimes pressure can also relieve from the lower MCBD, and so
Yes.
you should know it that way.
So summary, you should try to use minimum words possible, and obviously there should be no repetition. In the third line, you have already said that there is loss of weight. There is no need to add at the end that history of significant weight loss. There only you should have said that he has loss of appetite and significant weight loss.
Yes, sir. Yes, sir. Okay, sir.
Okay, please carry on.
Can I say something? Dr. Supratik,
Yes, yes, sir.
good presentation till now, right?
Yes, sir.
That was wonderful.
Thank you, sir.
Just, I would like to take you back because you did present the summary as well. And in the history part, you said something
Yes.
regarding total complaints, the duration around for 3 months,
Yes, sir.
right? I need
Yes.
to know that you use the word since 3 months. Do you use the
Yes.
word since 3 months or something else? One of the very basic questions that I come across. Is it since 3 months or
Or
for
for
3
last-
months?
For last 3 months.
For, we don't use last with for, because for means it is already past. It is never in the future. History means it is always the past. When do you use since word? Can they be interchanged, or is it something that we need to be careful about? Okay, I would just clarify. Whenever you are
Yes, sir.
talking of the period of the time, it is for that duration. And whenever the point of time is clear, that since what time, since April,
Okay.
since May, since 15th of that particular month, since 93, then whenever the point of time is there, we always use since. Fair enough?
Okay, sir. Okay,
Try
sir.
not to
Okay.
do this grammatical mistake. Okay, number 2.
Okay, sir. Okay.
You said that patient had some prodromal symptoms.
He did not have any prodromal symptoms, sir.
Okay. Suppose this patient had fever along with some pain, right? Fever
Yes,
with
sir.
pain. Could you have
Okay.
suspicion of something else as well?
Sir, in my patient with all these complaints, if he also had complaints of fever and pain, then, sir, I would include, I would think in the lines of cholangitis, that the patient might be going into cholangitis due to obstructive jaundice.
Is it not possible in a case of a malignant jaundice that patient can have cholangitis?
Yes, sir, it is possible.
In which cases, what history would you take that the patient can have cholangitis in such patients?
So the fever in cholangitis is usually a high-grade fever, and it is often associated with rigors and chills.
Can it happen in malignant jaundice as well?
A patient with malignant obstructive jaundice, sir, can also have sir, cholangitis. He can present in cholangitis also, sir.
Can there be a
But-
part of a history or a part of a treatment in which this can precipitate?
Sir, if patient has undergone any endoscopic treatment, like if he has
Yes.
undergone any ERCP, then that can aggravate cholangitis, and sometimes it can be the only reason for causing cholangitis in the patient.
Yes, definitely. Wonderful. Wonderful.
Yes.
Thank you, Supati. Nice one.
Yeah.
Yes.
Continue with the examination finding. Now you will move on to these investigations also.
Yes, sir. So coming to his blood parameters, we found out that his hemoglobin levels were 15.4 gram per deciliter. His total counts were 10,000 per cubic millimeter. Platelet counts were 241,000 per cubic millimeter. His prothrombin time was 18.5 seconds and INR was 1.7. This is the LFT report of the patient. His total serum bilirubin was 16.29 milligrams per deciliter. Direct bilirubin was 9.32.
Sorry to interrupt you. As a general rule, because these days classes and even exams are conducted online, whenever you are shown a report or you are showing a report, there is no need to read it out. We can all read it. Give your interpretation.
So from the previous in this slide, sir, we can see that his counts, hemoglobin levels, and platelets are all within normal limits. His INR is, however, raised. It is 1.7.
So, Suprati, we will go with the MBBS style and a little MSS style. So you have very rightly showed the first investigation at the LFT. You will be asked in examination what investigation you will do first, and because we want to know, we want to supplant our, support our diagnosis, clinical diagnosis. So it should be what
Ultrasound.
No, it should be LFT, biochemical investigation.
LFT.
And LFT, what in LFT? So Professor Kapoor sir was saying that when you write everything, you just tell the inference that there is conjugated hyperbilirubinemia. Okay.
Yes,
Ye
sir.
batana,
Yes.
right. This is
Yes.
important.
Okay.
And then the second important investigation would be ultrasound. Yeah, I agree
Yes,
with
sir.
ultrasound. So,
Yes, sir.
and in the biochemical or LFT, what other investigation you would see?
Sir, in LFT, apart from the bilirubin, direct and indirect, I would also look at alkaline phosphatase. And
Hyperbilirubinemia and alkaline phosphatase.
yes, sir.
Okay.
Yes, sir.
And then an ultrasound, you will go for ultrasound of the hepatobiliary system. Why did you
Yes,
say
sir.
ultrasound?
Sir, ultrasound, first of all, it is easily available, and the first investigation to be done in to evaluate any abdominal pathologies. It is readily available, and the sensitivity is very high for detecting any gall lesions, any lumps related to gallbladder.
So if you do, say, for example, if you go with, sir, Kapoor sir, you wanted to ask some question in the LFT and other thing, then you can carry on.
Why the enzymes are raised? You said this obstructive jaundice.
Yes, sir. Sir, in obstructive jaundice, sir, there can be often there is alkaline phosphatase is raised, but sometimes, sir, ALT can also be raised in later in the pathology due to portal biliopathy, sir. There will be destruction of hepatocytes later in the disease, which can also lead to rise in alkaline AST and ALT.
What is the more common cause of enzymes being raised in obstructive jaundice? It is subclinical cholangitis. If you look at the counts, they were not abnormal, but they were in the higher range of normal. You should have said that I would like to see at the differential count also. With a TLC of 10,000, if the neutrophils are more than 70-75%, then that could be an indicator that there is some sepsis going on, and probably it is subclinical cholangitis. You should also have commented that his albumin level is not normal. It is 3.1 or 3.2.
Yes, sir. Yes, sir.
Less than normal. So that indicates, corroborates with his weight loss. So any abnormal test which is shown to you, you should point it out.
Yes. Yes.
Okay. So ultrasound, Dr. Abhinav asked you, see, whenever you are dealing with jaundice here, of course, the history is quite characteristic and suggestive of obstructive jaundice. But the first aim of doing ultrasound in a patient with jaundice is to differentiate between hepatocellular and obstructive jaundice. 2 or 3 days after the onset of jaundice, if there is no IHBRD, then it is not obstructive jaundice. Next aim of ultrasound is to find out the level of obstruction.
Yes, sir.
The third aim is to find out the cause of obstruction. Okay, let's see the
Sir, in this slide, sir, I have mentioned the USG report of the patient. So on USG, there was a mass seen at the neck region of the gallbladder with a wall thickness of 7 millimeter at the neck. There were enlarged portal lymph nodes. Moderate IHBRD was noted. The proximal CVD was not dilated. However, the diameter was 5 mm. The distal CVD could not be visualized in the sonography. There were no free fluid in the peritoneal cavity.
Now, please.
Yes, please.
I think ultrasound whole abdomen, should we call it ultrasound whole abdomen? They should categorically write something else also.
Trans-abdominal ultrasound.
No, that is okay. Ultrasound trans-abdominally, but should they be writing something else? I mean, negative history भी लिख देनी चाहिए थी. fetal metastasis, you have written, नहीं लिखा है ना कहीं पे, liver and diaphragm, specifically in Blummer shelf PR polyphonic should have.
Yes, sir. Yes, sir.
Sir, आप पूछिए फिर we will come back. Kapoor sir.
So from this ultrasound, what do you think is the level of obstruction?
Sir, the level of obstruction will be around the hilum, sir. Should
Is
be
it-
around the hilum.
If there is obstruction at the hilum, will the proximal CBD be seen?
No, sir, it will not be seen properly.
The radiologists always call it proximal CBD. Actually, it is CHD, but that's
Yes,
fine.
sir.
So
Yes,
if
sir.
ultrasound can tell you the level of obstruction, if it is obstructive jaundice, the IHBR will be dilated.
Yes, sir.
If hilar block, then the two ducts, right and left, will not meet each other. That means confluence is not patent.
Yes, sir. Yes, sir.
Confluence is patent, but proximal ducts are not seen, that is the common hepatic duct is not seen, then it is a subhilar or a type 1 cholangiocarcinoma. If
Yes, sir.
IHBRD is there, confluence is forming, and the common hepatic duct is dilated, but the CBD is not dilated, then it is a mid CBD block, the commonest cause of which, at least in North India and Central India, is gallbladder cancer. In the West, it would be a cholangiocarcinoma.
Yes, sir.
If you see mid CBD block and you also see a large stone sitting next to it, then it could be Mirizzi. That is the classical presentation of Mirizzi, that you have a mid CBD block and a large stone in the neck of the gallbladder. If you see CBD dilated till the lower end, then it is a lower end cholangiocarcinoma. If you see CBD dilated till the lower end and the main pancreatic duct is also dilated, and the two dilated ducts are approximating each other, it is a periampullary carcinoma. If the CBD is dilated till lower end, main pancreatic duct is also dilated, but the two ducts are not meeting each other. They are separated from each other, which means that there is a mass there, then it is a pancreatic head cancer. So a good ultrasound can virtually give you the diagnosis in a large number of cases. So here, based on the fact that they have said proximal CBD diameter is 5 millimeter, distal CBD is not seen, most probably it is a mid CBD block, which is caused by the tumor in the neck of the gallbladder, which is directly infiltrating the common bile duct.
Yes, sir. Yes, sir.
The exam, if you are shown a report like this, as Dr. Abhinav said, you should have said that I would like to know whether there is any ascites, whether there is any SOL in the liver. But
sir.
since it is not mentioned, I presume that
It is not there. It is not.
Yes, sir.
You have to say.
Yes,
You have to say.
Yes, sir. Yes, sir. Yes, sir.
Because it will say, the examiner would think that you are thinking on the right path. I mean,
Yes, sir.
radiologist is also human. He would also, forget to write few things.
Yes, sir.
And yeah, तो continue करें फिर एक बात आपने कुछ नहीं करना पड़ेगा.
Okay, what next?
Sir, I also have the CT scan report of the patient.
What would you have done after this ultrasound?
Sir, after this ultrasound, as I could clearly see that they are mentioning mass in the neck region of the gallbladder.
Answer.
So the next,
give the answer first. Don't give the explanation. This is another very frequent mistake which students make. When a question is asked, they start giving the explanation first. First, give the answer.
sir, I would like to do a staging CT scan for the patient.
CT of the
CT abdomen, contrast CT of the abdomen, triple
Only-
phase.
only abdomen.
Abdomen, pelvis, and thorax, sir.
Suppose CT thorax shows a pulmonary metastasis.
Sir,
In
if
your
CT,
clinical practice as well as in the exam, in all patients with malignancy, you must do and you must say a chest X-ray. Many examiners will catch you on this, and you will burn your fingers in your clinical practice also that you do a CT of the chest, you find a pulmonary metastasis which could have easily been picked up on the chest X-ray. So by and large, in most malignancies, a chest X-ray and if relevant, an abdominal ultrasound is a must before you go on to expensive, invasive, or radiation-based investigations. Okay, let's see the CT. Why CT? Any other investigation which can be done in a patient with jaundice?
Sir, MRI with MRCP can also be done, but since we are thinking in lines of malignancy, CT would be a better option, sir, in this case.
So you mean to say in malignant obstructive jaundice, there is no role for MRI?
There is role for MRI, sir.
So when would you do CT and when would you do MRI? By and large, you are an MS student, isn't it? Yes.
Yes, sir.
By and large, for
Sir,
you people, if it is a high block, that is hilar cholangiocarcinoma
Carcinoma.
or a gallbladder cancer, many centers
CTs.
now would do an MRI with MRCP and MR-angio. You have to mention all three, MRI, MRC,
Yes.
and MRA. For lower end block, that is pancreas and pancreatic cancer, and many people for even gallbladder cancer prefer to do a CT scan. Okay, but theoretically speaking, you can get almost all the information that you get from CT from an MRI also. Although in practice, most people do a CT scan.
But
Let's
they
see.
really the same CT and MRI and need the same sensitivity specificity. And then benefit of going for MRI, MRCP is also because you would anyways be trying, ERCP. If you go for ERCP plus minus, it will help you. Okay, because it should be the anatomical roadmap. Yeah, MRCP, one investigation, you get all three different various interpretations and you save on money. Sir.
Okay, let's see the CT report.
So this is the CT report. In the CT, it is mentioned that the gallbladder is well distended. It shows a focal asymmetrical irregular heterogeneous enhancing mass with thickness of 7.2 millimeter in the GB neck, which is showing loss of mural stratification with ill-defined mass-like infiltration into adjacent porta hepatis. It is encasing the cystic duct, common hepatic duct, reaching up to the primary confluence, resulting in mild to moderate upstream bilobar, central, and peripheral IHPRD. It is completely extending along the course of CHD and proximal CBD, resulting in non-visualization of lumen. The distal CBD is non-dilated. It is abutting the main portal vein near porta hepatis. However, the portal vein appears normal in caliber and there was no filling defect inside it. It was abutting the hepatic artery and cystic duct. The fat planes with the adjacent pyloroduodenal junction, that is D1 and D2, are lost. So there was a loss of fat planes with duodenum. The fat planes with hepatic flexure was also indistinct. Superiorly, it shows lot of fat planes with adjacent hepatic parenchyma, that is segment 3 and 4B. It was lying close proximity to IVC and right renal vein with maintained fat planes. So similarly, in the fundus region also, there was wall thickening noted, and it was showing loss of fat planes with adjacent hepatic parenchyma. This is the CT image, sir.
Okay, I think the image is not very good, so make out. We will have to go by the report only.
Yes, sir.
So what is your overall analysis of this report?
Sir, it is a GB malignancy. A growth is seen in the GB, which is infiltrating at least two of the surrounding structures. First of all, it is infiltrating the proximal CBD, and it is all the fat planes with duodenum is also lost, and there is indistinct fat planes with hepatic flexure. So it becomes a T4 disease, sir.
And there is liver infiltration also. Liver is also considered.
Segment 4, 3, and 4B are also involved. So greater than equal to 2 adjacent organs are involved. So my interpretation will be a T4 disease.
Although I'm not sure they have written segment 3. Segment 3 is very, very unlikely to be
Very
involved.
unlikely typo error होगा sir वो.
So either it is if you have copied the report or typed the report, it may be segment 5. 5 and 4B are the segments which are
Yes, sir.
likely involved.
Yes, sir. Yes.
There is a question in the chat which I think we can take, that in CAGB, AJCC 8 includes staging based on layers involved which are not well differentiated.
On CT scan.
Oh, no, T2A and T2B is not on layer. T2A and T2B
1A and TB.
on which side of the gallbladder, whether it is the peritoneal side or the hepatic side.
Yeah.
It can be made out on any investigation, ultrasound, CT or MRI. So that is
Yes,
not the.
I think he was confused with T1A and T1B probably.
Yeah,
Probably.
T1A and T1B, yes.
But
But
CT
that
and
cannot
MRI
be
both
made out
cannot.
CT or MR, that you can make out either on a
Yes,
very good
Professor.
endoscopic ultrasound or only on histology.
Yes. Yes.
So what is your overall impression of this CT? Do you think it is a resectable lesion or an unresectable lesion?
Sir, it looks like an unresectable disease, sir.
Why?
So first of all, T4 staging is there. That is, there are more than 2 adjacent organs involved. And in the second part of the report, so it was also mentioned that the pancreatic or duodenal lymph nodes were also involved, which classifies this as N2 disease. So T4 N2 disease is unresectable, sir.
What is T4? T4 is, you said, more than 2 organs, isn't it?
Yes, sir.
It depends on which organ. Suppose liver, omentum, colon are involved. It doesn't make it technically unresectable. Technical unresectability in gallbladder cancer is only main vessels involved.
Yes,
The
sir. Main portal vein.
Even
Yes, sir.
involvement of the right pedicle doesn't make it unresectable because you can still do right hepatectomy. CBD involvement doesn't make it unresectable. You can do CBD excision. Colonic involvement doesn't make it unresectable. You can do a segmental colonic resection. Duodenal involvement doesn't make it unresectable. As Dr. Anil Agrawal from GB Pant Hospital has shown, depending on the extent of duodenal involvement, you can do a sleeve resection, you can do a segmental resection, and if you are very aggressive, you can even do a pancreatoduodenectomy. So technically speaking, involvement of these structures does not make it unresectable. What you can say is that more of these structures are involved, the outcome in terms of survival is poorer. And that is why more and more groups are not doing such extensive resections. Technical unresectability is only the vascular involvement. Second, you said pancreatico-duodenal lymph nodes. Now, at your level, I think it's good enough to know that pancreatico-duodenal lymph nodes do not make it unresectable, because when you do lymphadenectomy for gallbladder cancer, you remove those nodes. That is the Western philosophy. Most Japanese surgeons and almost all Indian surgeons do not consider pancreatico-duodenal node involvement to be a contraindication for resection. It is only distant node. Distant nodes means celiac, superior mesenteric, and aortic. They make it unresectable. But yes, I agree with you that by and large, looking at this, it appears that it is unlikely to be resectable, at least for a good outcome.
Yes.
Okay, suppose it was not so extensive. Suppose it was only confined to neck of the gallbladder and CBD and some liver infiltration. Then you would have said it is resectable, isn't it?
Yes, sir.
So what procedure would you plan?
Sir, in such condition, I would like to plan for radical cholecystectomy with CBD excision, if CBD is also involved.
Any other investigation before you go for operation?
Sir,
is there any other investigation which can tell you about distant metastasis?
Sir, I would like to order PET CT scan in such condition.
As a courtesy, you don't order, you ask for.
Yeah, I asked. Yes. Sorry, sir.
Sir, ordering
Sorry,
is done only in a restaurant.
Sorry,
Okay.
sir.
So what is the role of PET scan in gallbladder cancer?
Sir, PET scan is required in T2 or T3 disease if it is incidentally detected to look for metastatic disease, sir.
We are not talking of incidental. We are talking of primary gallbladder cancer.
Sir, if you want to look for any distant metastasis, sir.
Do you want to look for them or no? So the answer is that there is more and more evidence coming in, and these are reports from our own country, from Tata Memorial Hospital, from Rajiv Gandhi Cancer Hospital, Dr. Shiven Singh, from PGI Chandigarh, that in a large number, and some groups say in all patients with gallbladder cancer, if cost and affordability is not an issue, it is always good to do a PET scan because it will show you extra-abdominal and distant intra-abdominal disease, which if it is there, is a definite contraindication for any surgical procedure. So in summary, that is the answer for a PET scan. Okay, PET scan done, no distant disease. Dr. Kanagavel, please stop us when we exceed our time. I think we are already more than an hour.
More than an hour.
Sir, we will wind up this case in another 5-10 minutes, sir. We have one more case discussion
Yes,
to
yes,
go after this.
that is why I just noticed that we've already exceeded 9.
Yes, sir. I just want to, as the intensity was going good, I didn't feel like
No.
stopping as the data exchange, the knowledge exchange is good. Sir, we'll finish in another 5 to 7 minutes, sir. Then move on to the next case.
More
Sir,
questions?
normally we allow the candidates also to ask any doubts to be clarified at the end of the presentation. Sir, please allow a couple of minutes for that to be done. Sir.
Just one more question. Before doing
Please.
the anatomy, would you do something else?
Yes, sir. Could not hear, sir.
Hmm?
Sir, I could not hear the question, sir.
Before you open the abdomen, a PET
Yes,
scan
sir.
is normal. It is a resectable disease on CT scan. Any other?
Sir, I would like to go for a diagnostic lab, sir.
Called staging lab. Diagnosis is already made. It should be called staging
Staging
lab.
lab. Yes, sir. Sorry, sir. Staging lab.
Both we at SCPGI and Dr. Anil Agrawal, we strongly recommend that all patients with gallbladder cancer, before you take them up for definitive surgery, they must have a staging laparoscopy.
Yes, sir.
Okay, I think we'll stop at that. There is a question in the chat, role of neoadjuvant chemotherapy in gallbladder cancer. It is not a standard of care. There are some publications which show that if it is a non-metastatic, locally advanced, possibly unresectable disease, you may give neoadjuvant chemotherapy and see what is the response. But it is not still a standard of care, like in many other malignancies.
Yes, sir.
So I think I'll stop there. Abhinav, you want to make any concluding remarks?
I just wanted to ask you rather because this PET-CT debate is raging nowadays in cancer gallbladder. And if I'm not wrong, NCCN doesn't recommend going for PET-CT. So it always creates, little confusion. But yes, disease of Indian origin. So if save some money and energy, we should go for it. Secondly, this is protocol of MD Anderson long back, 10, 15 years back. They have started doing, staging laparoscopy for cancer gallbladder and then proceeding with surgery. So it is good. Overall, you did a good presentation. You should ask questions if you have difficulty, You should ask questions.
I want to ask few questions from you.
Yeah. Huh?
Is there any role of biopsy before you go for a definitive surgery?
Sir, the pancreatic...
No, I'm not asking. No, I'm not asking you. I'm asking the student.
Okay.
No, I'm not asking you.
Sorry.
Where is the student? Dr. Shah, where are you?
Yes,
Sir.
sir. Yes, sir. Yes, sir.
Dr. Shah, are you there?
Yes, sir. Yes, sir. I'm here, sir.
Yeah, please tell.
No, sir. I would not like to do a biopsy for the patient, sir.
Why?
If the patient is operable and in that case, sir, doing a biopsy may lead to upstaging of the disease.
Okay.
There can also be gallbladder perforation, sir.
All right. Now, tell what are the various ways we can biopsy the gallbladder? We can take some cytological or histological things from the gallbladder.
Sir, we can take biopsy to transhepatic route, that is, we can go for FNAC, or we can also take brush cytology.
Yes. Can endoscopy help you in any way?
Yes, sir. Endoscopic brush cytology can be taken, sir. Or EUS guided biopsy can also be taken, sir.
You can do the US. You can take
Yes,
the
sir.
bile cytology. You know, bile coming
Yes,
out
sir.
from you
Yes.
can take the cytology of that.
Yes.
Now tell why the PET scan is not a standard of care in the 8th AJCC. What is the reason for that?
Sorry, sir. I'm not, sir, aware of this, sir.
Because the reason for that is because PET CT scan, not only finds the metastatic deposits, but any infective origin which is there.
Yes, sir.
Like a patient had a tuberculosis or the lungs are there. That will be picked up by the PET scan. And you will get a diagnosis that probably there are metastatic deposits in the lungs are there.
Yes, sir. Yes.
So there are many false positive results which are there. And that is why it has not become the standard of care, apart from the cost which is there involved in that. That is another reason that why it is not a standard of care. Okay, though it is good that you know it, but usually it is for the after you have done the definitive surgery or definitive treatment, then you go for the PET scan to look for the recurrence. Okay.
Dr. Supratik, do you have any questions or doubts to be clarified? Now you have known your lacunae from the faculty where you have to improve upon. So don't feel bad. I hope you have taken notes, which are the areas you find difficult. Get back to the library, catch up with the most recent developments on one side and standard of care. You go for the NCCN, again, sit back the NCCN, gallbladder carcinoma, full review again. See, the science is continuously evolving. See, you may not have one clear answer for certain areas. I'm sure the faculty has given a glimpse of the controversial areas or glimpse of science and research which is happening on certain areas, which may in future be applicable to the standard of care. So there are always developmental opportunities, pathways of corrections, which is always there. Things apart, as a student now, you are in a general surgery, you may take up oncology or GA surgery, whatever it is. For that, your fine-tuning of knowledge has to be there. So you just revisit this presentation. This is available in the recording. Go back, watch where are the areas you have stuck. Just refresh your knowledge, go back to the fundamentals, go back to the most recent advances textbook and brush your knowledge. So with that being said, do you have any doubts to be clarified with the faculty here? We have a very eminent national faculty team available here.
Yes, sir. I do have one question. Sir, in cases of incidentally detected gallbladder carcinoma, when we have already performed laparoscopic cholecystectomy, and if the report comes out to be a T2 disease, for example, in that case, when we go for again, we go for definitive management. In that case, do we usually perform port site excision, sir?
So in the initial days, there were a lot of reports which reported very high incidence of port site metastasis, and it became a routine to do a port site excision as a part of what we call completion extended or completion radical cholecystectomy. But recent evidence has shown that it is not of help in improving the outcome. And more groups have given up excising the port site. The only theoretical advantage is that if the port site shows a metastasis, then you can say that the outcome is going to be poor. But the excision has not shown to improve the survival, whether it is positive or negative.
So the only thing which has dented this port site metastasis is that if your suspicion a priori or you feel that patient could be having malignancy, you retrieve from your plastic bag.
So,
If you come in contact, there is less chance of the port site metastasis.
So thank you, Dr. Supratik. You can stay with us for the second case. Kapoor sir, we have a carcinoma of the tongue for the presentation. I wish you can be with us, sir, but I know your interest is in more in towards
Supratik.
GI and HPV surgery.
Carcinoma tongue bhi upper GI hai.
Supratik.
I will log out for some
Sir,
other.
1 second, sir. Kanganwal, sir.
Yes, sir. Who is this, please?
Sir, Kanganwal, sir.
I'm sorry for the inconvenience caused.
Sir, Kanganwal, sir.
Yes, sir.
Sir.
Who is this, please?
Dr.
Hello, sir.
Guzer is clearly.
Sir,
Dr. Guzer is asking
Yes, sir.
something.
Yes, sir. Yes, sir.
hello, Supratik.
Yes, sir. Yes, sir. Yes, sir.
Just want to add one point. Just now you talked about the port site port excision. There are different opinion in different books. Saviston
Yes, sir.
said port site to be excised. Then Bailey says routine excision of the port site is not performed. So these are our controversial points.
Yes, sir.
Okay.
Dr. Supratik,
Where is
I
the
also would like to come in here. See, with the level of advancements of imaging, none of the patient go for a cholecystectomy without a minimum basis of ultrasound, right? Now, the ultrasounds are so well developed. Any suspicion, the radiologist updates you that we are dealing something more than gallstones. So always you go for a additional imaging complementary to the ultrasound, right? So the chances of getting polyps as an indeterminate polyps, as a cholecystectomy and getting into these type of issues are pretty rare at this point of time. And enough evidences are coming up telling laparoscopic radical cholecystectomies are proving to be of good benefit. And then I'm sure with the large studies told, even where patients undergo radical cholecystectomies, their laparoscopic ports have not been proven to have increased metastasis when compared to an incidental cholecystectomy CAGB. Sir, Kapoor sir, correct me if I'm wrong. This data may be little old. What I'm quoting the paper right now is little old, I guess. But
Yeah.
one thing for sure, yes, sir, please.
Yeah, that's the problem with textbooks because they carry information which was there for many years ago.
Yes, sir.
And these are advancing and changing fields. I don't think final word has as yet been said on port site excision, but as I mentioned, more and more groups are moving away from it.
Got it, sir. Point is taken.
I put my email address in the chat. All students who are attending and who will be watching the video later, it's vkkapoor.india@gmail.com. Please send me a mail, write SOJ malignant in the subject of the mail. I'll be happy to send you the chapter on this topic from my book on clinical surgery.
Thank you very much, sir. Thank you very much.
I'll take leave and probably log out.
Thank you, sir. Thank you. Thank you, sir. Thank you for joining today.
Bye,
So, yes, sir. Good night, sir. Faculty, we move on to the next case. We have Dr. Sharath Chapili. Sharath is a postgraduate student from Apollo Institute of Medical Sciences, Hyderabad. Kindly contributed by Professor L. Sridhar and Professor Faiz, the unit chief. Dr. Sharath, you can start your presentation. Faculty, please take over. Good luck. This will be a short case, which will be completed in half an hour time. Thank you very much.
Yes, thank you, sir. Good evening, everyone. Today I'll be presenting a case of ulcer tongue. I'm Dr. Sharath Chandra Chapili from Apollo Institute of Medical Sciences and Research, Hyderabad. My HOD is Dr. L. Sridhar and my professor is Dr. Faiz Hussain. A 50-year-old gentleman, an agricultural laborer hailing from Nalgonda district, came to the OPD with the chief complaints of ulcer over the left side of tongue for 3 months. The patient was apparently all right 3 months ago. To start with, he noticed a painful ulcer over the left side of tongue, which is insidious in onset and gradually progressive from an initial size of approximately 1 by 1 centimeter to a present size of approximately 3 by 2 centimeters. Patient also complains of a swelling noted below the left lower jaw, which was insidious in onset and gradually progressive to an approximate size of 3 by 2 centimeters. There is a history of increased salivation, history of difficulty swallowing, history of difficulty in articulation, difficulty in protruding tongue, and there is history of chewing tobacco for 30 years, which he stopped 3 months ago. There is no history of bleeding or halitosis, no history of trauma or ear pain, or no difficulty in opening mouth. There are no loose teeth, no complaints of loss of sensation in the lower jaw, and there is no history suggestive of distant metastasis. In the past history, there are no known comorbidities. There is no history of low-dose irradiation in childhood. There is no history of cancer-related deaths in the family. Patient takes mixed diet, has adequate sleep. Bowel and bladder habits are regular. Patient is not an alcoholic or a smoker. In summary, a 50-year-old gentleman came with the chief complaints of ulcer over the left side of the tongue, which is insidious in onset and gradually progressive for 3 months, associated with increased salivation, difficulty in protruding tongue, difficulty in swallowing, and history of chewing tobacco for 30 years, which he stopped 3 months ago, with no symptoms as to of distant metastasis. But there is another swelling of size 3 by 2 centimeters in the left lower jaw.
Yeah. Can you, Sharad, go back to history for second slide? Yeah, history.
Yes, sir.
So the second slide. Now the next slide. History of increased salivation, difficulty in swallowing, difficulty in articulation, difficulty in protruding tongue. What is the meaning of all this?
The patient has observed there is a continuous dripping of saliva and he's carrying a cloth by his side to wipe it off, and he's
why I'm asking this, that this is still a very small disease T2 for oral tongue. Unlikely to, patient may have salivation, but when you say about difficulty in swallowing and ankyloglottal, difficulty in protruding tongue and difficulty in articulation, what does it mean if difficulty in swallowing? It shows that patient might be having, disease second down there also, and articulation once again means the same thing, that it has exceeded, gone on to the tip of the tongue. And when you say difficulty in protruding the tongue, it means floor of the mouth has also been involved. So this all talks about the severity of the higher stage of the disease. Okay.
Yes.
Next slide would be, could you show me the next slide? Why did you ask for no history of trauma, ear pain, opening of mouth, no loose teeth, no complaint of loss of the lower jaw, and history of suggested distant breath? The no history of trauma. Why in oral tongue you want to talk about history of trauma? What is the relevance of this finding? History.
Trauma by means of when the patient is chewing, there can be a repetitive trauma of the tongue, and due to sharp tooth.
Yeah. And what else? Ear pain and opening of the mouth.
Ear pain signifies about the involvement of auriculotemporal nerve, a referred pain which is referred to the external auditory canal via the lingual nerve and the auriculotemporal nerve.
And where is the lingual nerve?
Sorry, sir?
Where do you find lingual nerve?
In cases where the floor of mouth is involved.
And opening of the mouth?
If pterygoid muscles are involved, there would be difficulty in opening the mouth.
So if per primum the difficulty is opening of the mouth was not there, then you should, this talks about the, once again, of the severity of the disease, right? Pterygoid plate, this talks about the severity of the disease.
Yes.
Otherwise, it could be trismus, some because fibrosis, trismus causes some because fibrosis.
Yes.
Loose teeth?
Loose teeth can be the predisposing factor for history of trauma, sir. And if there is involvement of alveolar mandible in the alveoli,
primary alveolar disease would present as loose teeth. And the same would be important for no complaint sensation, loss of the lower jaw. Okay. Tongue involving the mandible, lower mandible would be rarer. This is what I want. Yeah, next slide here. Yeah, you can continue. And childhood radiation, in tongue, there is no role of previous irradiation. It's not like lymphoma where you have history of previous irradiation causing malignancy later on. Okay.
Yes, sir.
There is no role of irradiation in childhood. And who irradiates the tongue? I mean, you have to understand that. No? This part of history is little, far-fetched. And then history of complicated deaths in the family. This is not syndromic presentation. There is no familial, predisposition also. In cancer, this is not transmitted in genes and other related things. There is no syndromic presentation in the cancer tongue also.
Yes, sir.
Over to others here. You have finished the history and you come to the statement, huh?
Yes,
Yeah.
sir.
Please say again. Others will join.
Should I repeat the summary, sir?
Yeah, for others, yeah.
Yeah. A 50-year-old gentleman came with the complaints of an ulcer over the left side of the tongue, which is insidious in onset and gradually progressive for 3 months, associated with increased salivation, difficulty in protruding tongue, difficulty in swallowing, and history of chewing tobacco for 30 years, which he stopped 3 months ago, with no symptoms suggestive of distant metastasis.
Okay. So what is the question? It is, you're very simple to make diagnosis. Disease involving tongue. It looks like cancer on the tongue. And
Yes.
though it looks 3 into 2 centimeters, but by the history of whatever there's ankylosing, there is difficulty in swallowing. It looks like that it is much more than a T2 lesion. It is much more than a T2 lesion. Okay. This is
Yes.
evident from the history. If anybody else can answer the question.
What are the various pre-malignant conditions?
There are potentially malignant conditions are divided into 3 types, sir: high risk, intermediate risk, and low risk. High risk are hypoplastic candidiasis, varicose leukoplakia, and erythroplakia. And intermediate risk are oral submucous fibrosis. And low risk is discoid lupus and lichen planus.
All leukoplakia are likely to have the pre-malignant. All leukoplakia are likely to have the pre-malignancy.
No. Non-homogeneous type are usually have an increased risk of malignancy, sir.
Is leukoplakia more malignant or erythroplakia is more malignant?
Erythroplakia, sir. But a combination of leukoerythroplakia is more malignant compared to all the conditions.
Which leukoplakia is more malignant?
Varicose leukoplakia, sir.
Speckled leukoplakia.
Sir, speckled leukoplakia.
Okay.
Yes.
What is the definition of leukoplakia?
It's a clinically characterized by a white patch which cannot be rubbed off from the surface of the tongue, sir.
And you have to add that it could not be classified into any other condition.
Any other condition, yes.
Leukoplakia is a clinical diagnosis. Unlike varicose, unlike low-grade dysplasia, other things, it is more of a clinical diagnosis. It cannot be classified into other clinical diagnosis.
Yes, sir.
Next, क्या करेंगे? Examination finding.
Yes, sir. I examine the patient in a well-lit room after adequate exposure after taking an informed consent. Patient is conscious, coherent, cooperative, and comfortably sitting well hydrated, thin built, and patient looks malnourished with a BMI of 20.4 kilograms per meter square. ECOG score is 2. Vitals, the pulse rate is 84 per minute. Respiratory rate is 17 cycles per minute. Blood pressure is 130 over 70 millimeters of mercury, and the patient is afebrile. There is no evidence of pallor, icterus, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy. This is the clinical image of the patient. On examination of the head and neck, I examine the patient from in front and behind as and when needed. On inspection, facial symmetry is not maintained with a swelling in the left submandibular region, which will be discussed in the examination of the lymph nodes. The mouth opening is 6 centimeters. There is no halitosis. There is a 3 by 2 centimeter ulceroproliferative growth present over the left lateral side of the tongue, extending from the tip of the tongue anteriorly to 1 centimeter anterior to the circumvallate papillae posteriorly, 1 centimeter to the right of midline medially, and floor of the mouth laterally with averted edges, slough as base, surrounding erythema and no active discharge. The protrusion of tongue is absent and rest of the movements of the tongue are free. Oral hygiene is maintained. Staining of teeth is present. There are no sharp or loose teeth. The rest of the oral examination is normal. On palpation, tenderness is present over the ulcer. Inspectory findings are confirmed with induration as base and which is extending 1.5 centimeters from the ulceroproliferative growth. The depth of the ulcer is 1 centimeter from the lateral border of the tongue, and the examination of mandible is normal. Examination of the neck. A hard tender fixed lymph node of size 3 by 3 centimeters with a 0.5 by 0.5 centimeter ulceration is noted over the level 1A region on the left side. And a hard tender solitary lymph node of size 1 by 1 centimeter is palpable in level 1B on the left side. Then there are no other lymph nodes palpable in the neck. Systemic examination, CVS, the S1 and S2 are heard. There are no murmurs. Respiratory system, normal vesicular bed sounds heard, no added sounds. Abdominal examination, soft, non-tender abdomen with no organomegaly or lumps palpable. In CNS examination, there is no focal neurological deficit noted. Summary. A 50-year-old gentleman with complaints of the ulcer over the left side of the tongue, which is insidious in onset and gradually progressive for 3 months, associated with increased salivation, difficulty in protruding tongue, difficulty in swallowing, and history of chewing tobacco for 30 years, which is stopped 3 months ago. On examination, there is a 3 by 2 centimeter ulceroproliferative growth with averted edges and surrounding induration over the left lateral border of the tongue crossing the midline, and multiple palpable hard lymph nodes present in the ipsilateral level 1A and 1B regions. Diagnosis: carcinoma of the tongue with ipsilateral level 1A and 1B lymphadenopathy with a clinical staging of T4, N3B, and M0.
Yeah. Sarath, you did the right thing, but in examination, when you were writing the summary, you should have also written you should remove this ulcer is 3 into 2 centimeters, but the malignancy is more than 3 into 2 centimeters, right? You should not put a focus on the ulcer. Actually, when you present the ulcer, it is okay in history, but examination, you have to write the diameter of the whole disease. So this T4 is okay, and T4, what T4A or B?
T4A, sir.
Yeah, T4A is good. So T4A and 3B is okay. N3, why did you say N3? By the way, you said there is no lymph node anywhere else.
Yes, sir, there are lymph nodes present in the 1A and 1B region, sir, but the lymph nodes in the 1A region are fixed to the mandible there. So extranodal extensions are considered as 3B and 3B.
Okay, so what will you do now? Kya karenge? Khanna sir, or anybody else would like to ask question? Sir? Yeah, what will you do now?
I would like to confirm my diagnosis first with the radiological investigation of MRI, sir.
No, I can't confirm diagnosis with radiological investigation.
What will you do? I mean,
I would do a wedge biopsy to know the.
You should do a wedge biopsy.
Yes, sir.
Okay, you should do a wedge biopsy. Now, what will you find in wedge biopsy? What will it say?
The most common carcinoma in the tongue is squamous cell carcinoma of the tongue.
Yeah. What are the other uncommon cancers of the oral cavity?
Melanoma.
Don't say melanoma, yaar. Melanoma is very rare. The other less common variety is the 5% soft tissue sarcomas of the oral cavity, sarcomatous lesions of the oral cavity, and melanoma is still rare. Okay.
Yes.
Now, you made diagnosis by squamous cell cancer of the oral cavity, T4A, N2, N3, and now it is known. What kind of malignancy is this? It is a locally advanced.
Locally advanced man.
Clinically, what will anybody be able to operate this patient or not? Clinically, what is the gut feeling? All right. Before you move on to this, now you would need an imaging. Sahid sir, you wanted to ask questions, sir.
Yeah, I just want to ask him, what's the difference between T4A and T4B in oral cancer?
T4B consists of involvement of the pterygoid muscles and
two very important structures, carotids and base of skull. Right?
What he is trying to say, you have also to understand, till T4A, patient is an operable cancer, operable variety. The moment it moves on to T4B, the cancer becomes inoperable. Okay?
Inoperable.
Right. You have to remember this also. Okay?
Yes, sir.
Puche sir, puche. See, now, what imaging would you order? And why?
As it is,
do you feel he is operable patient or not? I mean, once again, I'm going to that. Say, what on imaging you would like to see? What imaging, CT or MRI, and what? Why? And we'll talk about the plan.
Remember, it's T4A according to you clinically.
Yes.
So, what do you plan to pick up on T4A?
To know the skull base involvement, we'll do a CT head and neck.
First, you must say to confirm whether these things are involved, and second is whether these things are not involved. Right?
Yes, sir.
So, what structures do you think in T4A is involved, and how will you investigate?
Floor of the mouth, involvement of the floor of the mouth, and involvement
you have
of the mandible.
Look, you have the bone, you have the nerve, and you have the soft tissue.
Yes.
The floor of the mouth, the skin, all that stuff.
Yes, sir.
So now, how will you find out whether the bone is involved, the nerve is involved, or the soft tissue is involved?
For the involvement of bone, we do a CT of the head and neck cell. And to find out the involvement of nerves or in the soft tissue around, we prefer an MRI. We go for an MRI. Head and neck.
Okay. So you can't get the soft tissue with a CT, or you can't just do an MRI and get away with it. Why do you need a CT scan then?
Involvement of mandible is more bone is clearly seen in CT scans.
You think MRI will not give you up the bone?
The resolution of bones and bony windows are good in CT scan. Then you can also do 3D reconstruction. You can do as MRI also can do it. But MRI, he's rightly said, as MRI is good for soft tissue. And MRI is, CT scan is good for bones and soft tissues are good, but CT scan would not be in a later stage if you plan, give neoadjuvant chemoradiotherapy and then operate. And then you want to see whether recurrence is there, response treatment is there. CT scan won't be of any help because the scar tissue would look like a disease also or normal tissue. It would
right.
Be
Another reason is that CT will show you the base of skull.
Yes.
Right. So with one armament, I'm proving something and I'm ruling out other things.
Yes.
Right. Okay. So please.
So what is the stage of the patient? Stage is there. So
actually, I would like to do an ultrasound also before he goes for CT, but he's not doing that.
Ultrasound of a neck for
ultrasound of the neck.
So क्या करेंगे वो? He has. Sharad, I'm saying ultrasound of the neck is not needed as far as I am concerned. Level 1 and level 2, level 1B, lymph node and 2 are already involved. So what the depth of invasion is more than 4 millimeters. When the disease is T1, there is 15% chance of involvement of the local neck, regional lymph node. And T4 disease, I do expect at least lymph node, majority of the lymph node would be involved. CT scan would be a good investigation to tell you about whether the lymph nodes are involved or not, right?
Yes.
So the approach is that this is patient with T4A, and 3. What we will be able to do in view of the ankyloglossia, difficulty in swallowing, difficulty in articulation, patient floor of mouth is also involved. Now I will have to do an upper GI endoscopy. I will have to see whether the valvula, the posterior third of tongue, and these all are involved or not, oropharynx and hypopharynx are involved or not. If they are not involved, then probably patient is a candidate for surgery. Or if they are involved, patient is not a candidate for surgery, and the survival is very bad. For a 1 year survival, I would say 5-year survival of these kind of patients is less than 5% or so. Okay.
Yes.
So this form he's a locally advanced kind of a disease, and oral cancer, once cancers where the role of chemotherapy is not there, not of much use. I mean, this is it. This is it. I mean, I would like to treat more on the lines of palliative management rather than the intention.
So, any role of FNAC for the lymph nodes?
Pardon?
Any role of FNAC from the lymph nodes?
So, level 2, 1B lymph node is seen visible there. It 1B is visible. So, I mean, it won't be of much help. It will only tell you. You can even make an imprint cytology.
Now, what if the students are asked in the exam?
Students, the ultrasound is very famously being said to, find out whether the lymph nodes are involved or not.
Right.
Practically speaking, the knowledge of why patient spend another 15 or 2,000 rupees for a lymph node. This patient, anybody anyway is going to receive palliative radiotherapy, and therefore, if you are going for treatment of the patient, he would anybody his regional lymph node area would be covered. Now, I would tell you why I don't go for lymph node examination or for ultrasound is that if you have ordered CT scan will be able to tell. But lymph nodes are better. Ultrasound is better to delineate, find out whether the malignancy is involved in lymph node or not. Number one. In this particular case, say for example, had this been an operable patient, I still wouldn't have gone for ultrasound of the neck because of the simple reason, sir, that whenever there is a T1 or T2 disease with a 15% chance of lymphatic metastasis to the regional lymph node basin, you have to do some kind of lymph node dissection. It could be a supramoid neck dissection. It could be a modified neck dissection of any type.
Yes, sir.
Okay. Now, when you're going for all this, so I think I would save some money on for not going for
Ultrasound.
ultrasound of the regional lymph node, neck node.
Okay, I would just like to ask you, what do you think on ultrasound will distinguish it malignant lymph node from a benign lymph node?
Infective.
On ultrasound?
Malignant lymph nodes, there is a loss of the bean shaped becomes a spherical shape where there is a loss of fatty hilum of the lymph node, and they become hypoechoic and they look hypoechoic. The malignant lymph nodes look hypoechoic.
Right.
Why is your patient, which T4 it is, A or B?
A, sir.
T4A. What are the components of the T4B? T4B
Involvement of skull base, carotid involvement,
and
involvement of the pterygoids.
Pterygoid plate, not involvement of pterygoid.
Yes,
any involvement of pterygoid below the jugular notch is operable even. Okay, when they get involved, the attachment at the pterygoid plate is involved, out base of the skull, this is T4B, right?
Yes.
And what is N3B?
N3B is any lymph node with extranodal extension is considered as N3B. Sir.
Okay. So why you are keeping it as a N3B here?
The lymph nodes in level 1A region involve the bone and they form an ulceration over the skin in the below the lower jaw.
What is the difference between a HPV infection and non-infection oral cancer?
HPV infection, the cancer post HPV infection usually have a good prognosis, sir. Well,
what are the various differences between these two? HPV plus, HPV minus. Tell the characteristics of the HPV positive oral cancers. They are usually young, usually have a good prognosis. They have got the advanced stage Usually it is not the oral cancer, but the oropharyngeal cancer. Okay, so if somebody has got the HB positive, then think into it.
Okay, can you tell me the prognostic factors for this patient? Hello?
Yes, sir. Yes, sir.
Can you tell me the prognostic predictors? How will you know what is the prognosis of this patient? Any parameters to decide?
The lymph node is the most, if the lymph nodes are positive, it is the most
Okay, that's the
deciding
most
factor on the
important. That's
prognosis.
one.
Yes.
Okay, very good. Lymph node is one.
And if lymph nodes are negative, the grade of the tumor, if it's
Okay, look. Let's divide to three. It's epidemiological, like patient's age, sex, alcohol, tobacco, all the kind of stuff, all the risk
Yes.
factors on the pre-malignant conditions. The clinical parameters,
Yes.
that is the TNM, the grade, right? All that stuff,
Yes.
tumor location, all that stuff, and of course the histological, that is grading and perineural and perivascular and depth of invasion. So these are the predictors, right? So you
Yes.
divide into three: the patient conditions, the clinical parameters, and the histopathological.
As far as the epidemiological factors are concerned, considering the age of the patient and the non-HPV type, and the aggressive growth of the tumor in the last 3 months with no symptoms before that.
So that's the grading of the tumor, okay?
Yes.
Okay. So please.
I think now this tumor is little on the inoperable side, on the side. So
Yes.
treatment should be, what should be the normal treatment is that we should
there is
try
an
to
extranodal in extension present. I'd go with radiotherapy first, sir.
Yeah.
What kind of RT? What kind of RT?
Intensity modulated radiotherapy.
IMRT, okay.
IMRT.
Right. What about concurrent chemoradios? What's the role of concurrent chemoradio?
Then along with cisplatin, there to sensitize the tissue for the radiotherapy is given.
No, he's asking, when you give chemotherapy at the radiosensitizer, why do you give chemotherapy? See, the intention is whether you want to palliate the symptoms of disease or you want to treat with the definitive treatment curative protocol. If the intention to cure is there, then only probably you should go for chemoradiotherapy protocols. Otherwise, definitive radiotherapy protocols are not good for these patients. They would more for a palliative side. In palliative protocol, we mostly give a certain amount of radiation, not even full-blown radiation, which controls the disease because the outlook is not good for the patient. So, यही पूछना चाह रहे हैं कुछ और कम?
Because if you just give radio also, you have to give a higher dose, and
I
that
think
can lead to...
you would not get the full dose of the radiation because in palliative,
right.
You don't get the what is palliative radiation is equal to surgery. It's for local regional control of the disease. So he is not going to be a beneficiary of that exactly. So you will only give a certain amount of radiation, control the disease, his symptoms improve, and then that's it.
Okay, what complications will you expect in this patient? Hello?
Yes, sir.
What complications will you expect in this patient?
Aspiration, sir. Aspiration
what?
No, complication, aspiration is one problem. What is going to be the other problem? This is what he's saying, and that is why he needs some kind of radiation also. How patients of, in other words, sir is asking, how the patients of cancer tongue proceed. They will have second problem is they will not be able to eat properly. So they will die and inanition, number one. Number two, will also have torrential bleeding from the erosion of the
Bleeding.
artery.
Yes.
Okay. These two are very life-threatening, and then sudden aspiration, sudden tumor breaks into the larynx and patient dies. These are another problem.
So they have bleeding, they have fever, they have secondary infection, oral hygiene becomes much poor, he can't eat, can't swallow, becomes painful, and later on erosion of the lymph nodes and the blood vessels, and they die. Right?
Carotid blowout is.
So anything, sir?
I think this is enough for, sir, Khanna sir, the question.
Like in case if you want to, like, given the patient neoadjuvant chemotherapy and radiotherapy, and this disease becomes operable.
Yes, sir.
What are you going to do?
I would do a total glossectomy, sir, with reconstruction of the tongue.
The total glossectomy will be okay for this patient? Even if he has responded, will that be only thing you are going to do? What is commando's operation?
Along with the oral carcinoma, we remove.
What is commando's operation? Tell the full. What is commando?
Composite resection of the mandible is removed along with the malignancy, sir.
What is it called? Why is it called commando?
Composite resection of the mandible.
Commando is combined mandibulectomy and neck dissection operation.
Yes.
That is the full term of that, and commando's operation. So what does it comprise?
Involves mandibulectomy along with modified radical neck dissection or functional neck dissection as needed, along with the removal of the malignancy, oral malignancy.
So you think your patient will get away only with the total glossectomy, or you are going to remove the mandible as well as the?
Yes, my patient needs mandibulectomy also, sir, because the lymph nodes are fixed to the mandible, the joint of the mandible.
Right. Now, what incision you are going to make for doing a radical neck dissection?
Traditionally, Kreil's incision is taken for neck dissection, sir.
Mm-hmm. Any other incision?
Hockey stick incision.
Basically 2 flap, 3 flap, 4 flaps, you know?
Yeah.
Depending on the type of the Hayes Martin, Kreil's.
Schobinger's incision.
Yes. Now,
modified Schobinger's.
To prevent the carotid, you told about something about the carotid blowout. How will you prevent the carotid blowout when you're doing the neck dissection?
There are so many incisions for necks or a radical neck. Why are there so many incisions? What is so important about that? Sir just asked you. He's giving you a hint. Professor Khanna has asked you.
Yes, sir.
Why are there so many this kind of to prevent carotid blowout? Why? Why? Because of the danger of flap necrosis. Right?
So
if the flap goes,
yeah.
Sir, please.
Angle of your flap should not lie over the carotid vessels.
Carotid, yes.
Okay. But before that, it gets, if you are not sure whether this will blow out or not, can you do something at the time of the operation?
Mental patch graft is placed over the carotid sheath, sir.
Which patch? Bring the momentum there. So you have to open the abdomen for that.
What is
Can
locally available there? You put something which is available there locally. What is available in abdomen there? Muscle.
Platysma
No,
with the
not platysma. Platysma part of the skin.
It was too thin.
Right, there are a lot of muscles there. Levator scapulae, cover the carotid with some, because you have to give, in a situation where you will be operating and preventing blowout, you would like to cover it some kind of muscle, which is able to
Yes, sir.
absorb the radiation. Okay. So levator scapulae is there, or any muscle which can cover the carotids.
Yes.
which muscle is used when you're doing an inguinal block dissection to prevent the femoral blowout?
Out of syllabus.
Hmm? Do you know which muscle is
Gracilis.
used for that? Gracilis.
Gracilis.
Gracilis is not
Yes.
used. You need a very broad muscle for that. Usually the sartorius.
तो इसलिए एक और इम्पोर्टेंट है, वो पूरे ट्रायंगल की शेप में आती है वो.
So for the neck dissection, you can use the levator scapulae to cover
Levator
it.
scapulae. Yes.
So when you are doing the block dissection, what type of the block dissection you are doing? What are the various types of modified radical neck dissections?
There are 3 types, sir. Along with the 1, 2, 3 lymph nodes, if we preserve only spinal accessory nerve, it's type 1. If it's spinal accessory nerve along with IJV, it's type 2. And if it's spinal accessory nerve, IJV and sternocleidomastoid, it's type 3, sir.
So you are going to only remove level 1, 2, 3 only in the radical neck dissection. Modified
Radical neck dissection.
So I'm asking the modified radical neck dissection. So you're going to remove only 1, 2, 3 lymph nodes in modified radical neck dissection? Or you're talking
what are types of
supraomoid?
modified radical dissection?
In supraomoid, we remove only 1, 2, 3, sir. But in modified radical, we remove from level 1 to level 5 lymph nodes.
Yeah. Okay.
What are the modification? What is type 1, type 2, type 3? Type 2 structure is preserved.
Type 1, it's only spinal accessory nerve which is preserved, sir. Type 2, it's spinal accessory and internal jugular vein which are preserved. And in type 3, along spinal accessory nerve, internal jugular vein, and sternocleidomastoid are preserved.
Okay.
What is the difference between the right side neck dissection and the left side neck dissection?
Sorry, sir.
What is the difference between right side neck dissection and the left side neck dissection? Any extra structure which comes on the left side, which is in the lower part of the neck, do you get any extra structure there on the left side?
Thoracic duct.
Yes, that's a very important one, no?
Yes, sir.
What kind of neck dissection will you do here? This disease, post chemo, post radio, what kind of neck dissection will you do?
Bilateral radical neck dissection.
Yeah, you will do nothing less than radical neck dissection. See, oral cancer different from cancer of the breast, where you use neogen after anti-chemotherapy, you use new margin. But on oral cavity, you will always use the original margin. Original tumors, you tattoo it and that's the original margin. Okay.
Yes.
And in this particular patient where you suspect extracapsular spread of the disease in lymph node, nothing less than radical neck dissection.
Yes.
If you're doing the bilateral neck dissection, what precaution you will take?
At least preserve one IJV. Preserve one side of IJV should be preserved.
On which side? In your case, on which side you will preserve?
Right side, sir, because the disease is more prominent on the left side in the patient.
Preserved on the right side. Yeah.
Yes.
Okay. Dr. Kanagal, can you stop now?
Yeah, I think we are done. Yeah.
Sarth? Sarth?
That you
What
want
is
to
field
ask a question?
cancerization?
Sorry,
What
sir.
is field cancerization?
In cases of oral malignancy, there is a chance of multiple primary tumors originating from the oral cavity, sir. Because the insult happened is not localized to that particular region of the primary tumors.
Diffuse exposure
Yes, diffuse
to the
exposure.
malignancy. What is synchronous or what is metachronous?
If the second primary is seen in before 6 months of the first lesion, then it is called a synchronous lesion, sir. If the second lesion is seen after 6 months of the primary, it is called a metachronous lesion.
Okay. In the same area or in the different area? When you say it is a metachronous there,
If it should be
same
more than
area or a different
1.5
area?
0.5 centimeters away from the primary lesion, sir. If it's within the 0.5 centimeters, it is considered as recurrence of the primary lesion.
So like if somebody had a oral cancer and then the patient develops the breast cancer, will you call that as a metachronous or not?
No, sir.
No, that is also metachronous, you know. So it can occur in the same region or anywhere in the body. So
Okay.
that is a metachronous cancer, you know. Okay. Dr. Kanagale is there?
I think we can call it off, sir.
Yeah, we can.
So please,
Sir.
please, sir, let's see.
Thank you very much, Abhinav sir, for staying back till late night. And we wish to have you now and then whenever time permits for this session, sir. And also request you to kindly permit few of your PGs to be part of this teaching forum.
Sure.
This happens all Fridays, sir. And Dr. Sharad, do you have any questions or doubts to
Yes,
ask?
sir. Earlier also I was asked about the question of which neck dissection would you prefer in a patient. So how to decide on this? In this case, if there was a clear-cut extranodal extension, we went for a radical neck dissection, sir. But in cases of N1 or N2 lymphadenopathy, how to decide on which neck dissection to proceed with, sir?
See, the answer lies in the fact that majority of time the lymph nodes disease is not outside the lymph node, so you go for modified radical dissection anytime, type 1, 2, 3. Okay, so
Yes, sir.
the indication for radical dissection are N3 disease, post radiation, post chemo, recurrence. These are all indications for radical dissection. Anything other than you can go for modified radical dissection.
So for go for type 1, type 2 and 3, it's an intra-op decision to make, sir.
Normally you start with type 3. What is type 1, 2, 3? The structures there in the neck, important structures are nerve, spinal nerve, which is the motor nerve of the shoulder.
Yes, sir.
Hypojugular vein, and you have sternocleidomastoid muscle.
Sternocleidomastoid, yes, sir.
Sternocleidomastoid muscle is least important, but it gives, the shape of the neck. So it is more important for the cosmetic point of view.
Yes, sir.
So what is important is that you should start with the mRNA type 3, and as and when you feel there is some difficulty, you can remove it also. So for example, there are 2 lymph nodes are there, you feel they are malignant, then sitting right on the nerve, you can remove the nerve there. Because the primary intention is to do an arterial section.
Yes, sir.
So the Khanna sir was asking of the vein you would like to save is, which is the uninvolved side. In this case, left side has to be removed because it is the disease on the left side, but not necessarily. Okay.
Yes, sir.
Okay. Anything else?
That's it, sir. Thank you, sir.
Welcome.
Thank you very much, all the senior faculty here, Professor Abhinav sir and Professor Vikas sir from. I think today we have all the faculty from Lucknow. Dr. V.K. Kapoor was also from Lucknow some time back, and he moved to Jaipur after his retirement from the SGPGA. So, friends, we will meet you in the coming Friday. I thank our own faculty, Kanna sir, Rajiv sir, Nishikant sir, for staying with us all through. And we look forward to meeting you coming Friday. Thank you.